Hello, everyone. My name is Shekita Johnson, a pediatric nurse practitioner and DNP student from the University of South Alabama, and today I will be presenting my doctorate scholarly project on parental health literacy and childhood asthma, implementing an enhanced protocol to improve provider management of children with poorly controlled asthma. It can be understood that asthma can be a debilitating chronic illness that affects the quality of life of children of all ages. Numerous obstacles contribute to uncontrolled childhood asthma, which may include chronic family history of asthma, exposure to known environmental triggers, medical non-adherence to prescriptions. But this project will primarily focus on low health literacy among parents or caregivers, which in other words is defined as the educational grade level of parents or caregivers. According to Morrison et al., low health literacy in parents can potentially impact understanding of a child's diagnosis and treatment course. Health literacy could be defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. It has been recorded that only 12% of adults have proficient health literacy, according to the National Assessment of Adult Literacy. Nearly 9 out of 10 adults may lack the skills needed to manage their health and prevent disease. 14% of adults, which equates to 30 million people, have below basic health literacy, which is categorized as a grade level of 4th to 6th grade reading level. Adults with a below basic health literacy are more likely to report their health as poor, they may lack health insurance, and have been commonly categorized in minority populations, which pertains to my specific demographic in regards to this project. Focusing back on parental health literacy, we must look at the effects it may have in everyday life and in reference to asthma management. We must also look at additional barriers associated with low health literacy. This may include lack of understanding the continuous use of controller medications despite periods where there are no asthma flare-ups, disorganized family routines, which may prove to be a hindrance in asthma symptom control, lack of resources to aid in child rearing, which may also burden the parent, intentional non-adherence to medications due to low health literacy, and early childhood independence could also stem from low health literacy, which causes children to be more responsible for taking their medications at an earlier age. The goal is to provide a health literacy tool to establish caregiver baseline of educational reading level, to also introduce a low health literacy asthma action plan or picture-based asthma action plan to help caregivers have a better understanding of asthma medication and asthma symptom control, and to assess provider knowledge of parental health literacy levels via pre- and post-implementation surveys. A total of 29 parents of children and adolescents between the ages of 5 and 17 years old who were diagnosed with mild to severe persistent asthma were included in this scholarly project. Children under the age of 5 or over the age of 17, parents and children that were Spanish speaking, and patients who did not take an inhaled corticosteroid as a controller medication were excluded from this project. The project was conducted within the Asthma and Allergy Clinic located at Children's Healthcare of Atlanta, Hughes Spalding. 5 staff members that included physicians, nurse practitioners, and nursing staff were also surveyed within this project. The project investigator utilized the Rapid Estimate of Adult Health Literacy and Medicine short form tool to assess parental health literacy among caregivers prior to being seen by a provider. This tool consisted of 7 commonly used medical terminology that required parents to read aloud to the investigator. If words were mispronounced or paused on for more than 30 seconds, the point would be deducted from the overall score. Scores of 0 equated to a 3rd grade reading level or less. Scores between 1 and 3 equated to a 4th to 6th grade reading level. Scores ranging from 4 to 6 equated to a 7th to 8th grade reading level. And a score of 7 equated to a 9th grade reading level or higher. A picture-based asthma action plan was also introduced after the screening process and was conducted in a call and response method among parents. A pre- and post-implementation survey was given to providers, nursing staff, and respiratory therapists to assess baseline knowledge of parental health literacy and ways to improve education materials in current practice. This is a display of the data collection tools. The picture-based asthma action plan was also given as a refrigerator magnet keepsake as a token of appreciation for participating, and with hopes that parents will use them as reminders for better asthma symptom control. The common words that were utilized in the Realm short form tool were menopause, antibiotics, exercise, jaundice, rectal, anemia, and behavior. In regards to the Realm short form scores, 14 participants scored a 7 out of 7, 7 participants scored a 6 out of 7, 3 participants scored a 4 out of 7, 2 participants scored a 2 out of 7, and 1 participant scored 0 out of 7 out of refusal to read the medical terminology. Both parents with low health literacy and adequate health literacy endorsed a picture-based asthma action plan over the standardized written asthma action plan. It was also applauded by nursing staff and providers alike. 4 out of 5 providers and staff members did not have a way to ask caregivers what their highest level of education was prior to being seen. Only one nurse practitioner utilized a resource survey in primary practice that asked education status of parents during initial nursing assessment. Although a majority of the realm scores were adequate, there was still a moderate correlation in relation to low asthma control test and pulmonary function test, which still warrants a need to assess further barriers that could lead to uncontrolled asthma. Providers also stated a need for more picture-based and/or electronic devices that could be used to improve medication adherence in current practice. 83% of providers did not have a way to ask parents what their educational level was. While this was the case, providers had a majority perception that parents had a high school diploma or equivalent in educational level. Although it was seen that participants displayed an adequate health literacy level, there were still noted areas of poor asthma control based on asthma control test scores and pulmonary function test scores. An improvement was seen in a decline in emergency room visits and hospitalizations. And as stated before, parents verbally endorse understanding the picture-based asthma action plan better than the written asthma action plan. Overall, discovering a way that health literacy could be asked during initial nursing assessment could give providers a premise to better communicate with parents, leading to a more successful experience. Healthcare providers should automatically assume that every patient and caregiver has a low health literacy. Open communication is key to a successful provider-parent or patient relationship. And in discovering parents with low health literacy, simpler educational tools that are picture-based may prove more effective in parents' retention of knowledge. These are my references, and thank you again for listening to my presentation.